delighted to have Dr. Jeffrey Goldberger, who's representing the American Heart Association here as well, to talk about that topic.
Thank you, Drs. Antman and Rosenman, for the kind invitation to join you today. I hope to touch on bits and pieces of all of the prior presentations, the excellent presentations that you've heard regarding various aspects of atrial fibrillation in this talk about MRI imaging. In particular, I'd like to sort of reflect off of Dr. Antman's comments in his presentation. As he noted, the diagnostic workup for patients with atrial fibrillation, as published in our most recent guidelines in 2014, the recommended diagnostic evaluation includes history, physical examination, ECG, echocardiogram, and blood testing for thyroid and liver function. That's something that is essentially not changed in 3 decades. When I was a house officer, we did exactly the same thing. And when we talk about personalizing treatment for atrial fibrillation, we have to think about where the disease is. And disease in atrial fibrillation is, of course, in the atrium. Of the whole diagnostic evaluation, the only piece that even has a little bit of a focus on the atrium is the echocardiogram, where we can look at the left atrial size. And I can tell you that very few people today use anything about the left atrial size in the management of patients with atrial fibrillation. So I think ultimately, if we want to be able to better personalize treatment for atrial fibrillation, we're going to have to evaluate the left atrial substrate. Now, cardiac MRI is one tool to do this. There are certainly many other tools, and I think the future will be bright for us once we start to consider the broader evaluation of the left atrial substrate in patients with atrial fibrillation. These are some of the things that you can get from cardiac MRI. Of course, you can get all sorts of other information about ventricular function and hypertrophy, but I'm really focusing here on the atrium. I will touch briefly on left atrial size and function, then show you some data on left atrial fibrosis, but mostly I'll focus on a novel technique of 4D flow MRI to evaluate left atrial blood flow velocity and the impact this might have on risk stratification for stroke. Okay, so this is a cardiac MRI. You can see, I hope it's not too bright in here, but anyways, it's fairly easy to segment out the left atrium. This is a fairly easy way to measure left atrial size and then to even quantitate left atrial function if one needs to do so. Of course, this can be done by other techniques and is not really proven to be very useful yet in any of our evaluations. But certainly something nicely that can be done with cardiac MRI. One of the main advances in cardiac MRI is the use of gadolinium to develop delayed enhancement imaging. This was first applied in the setting of myocardial infarction. This is a pathologic specimen showing the myocardial infarction here, and here's delayed enhancement imaging showing the nice correlation of the scar fibrosis to the actual MI. The Utah group has pioneered the application of this methodology to the atrium. There are a lot of technical limitations in doing this in the atrium, and that's mostly related to the much thinner left atrial wall compared to the ventricular wall and the voxel size that we see in cardiac MRI. Nevertheless, the Utah group has been able to show, this is an example of an MRI where they've delineated the areas of fibrosis that they detected using delayed enhancement imaging. And they also did an electroanatomic map. So the purple is high voltage, and these are areas of low voltage. So you can see the areas of low voltage correspond to the areas of scarring or fibrosis seen here. The Utah group has subsequently done a multi-center study called the DCAF study, in which 329 patients who underwent catheter ablation for treatment of atrial fibrillation at multiple centers across the world, had cardiac MRI. All the analyses were performed at Utah, and they defined 4 different stages of fibrosis, whether there was less than 10% burden, 10 to 20% burden, 20 to 30% burden, and over 30% burden. And you see very nicely, just evaluation of the left atrial substrate of the fibrosis in these patients is a strong predictor of the outcome, this arrhythmia recurrence, after catheter ablation. Patients who have very little fibrosis do the best, and patients who have a lot of fibrosis, virtually none of them have successful ablations. So we can start to see that this evaluation of left atrial fibrosis can actually be very helpful in our decision making to try to decide who might benefit from catheter ablation and who might not. So moving on to our evaluation for stroke risk in patients with atrial fibrillation. You've heard a lot about this already. Just to highlight that 15 to 20% of all strokes occur in patients with atrial fibrillation. This is a huge public health burden, and we need to try to understand how to treat patients better with atrial fibrillation to avoid this problem. My particular interest in this really arose about 5 years ago when I saw these 2 patients 1 month apart from each other in my office. The first was a 47-year-old male who presented while he was on a business trip in Texas somewhere with a cerebellar stroke. He was found to have in the hospital paroxysmal atrial fibrillation, and a TE demonstrated thrombus. And then he came to see me for further treatment. He had no other prior medical history. Then the second one is a 50-year-old male who I'd been taking care of, who had paroxysmal atrial fibrillation. Again, no other medical problems. And one day he came into the office acting a little funny and ultimately was diagnosed with a right frontal lobe CVA. Both of these patients, prior to having their stroke, would have had a CHA2DS2-VASc score of 0 and would not have been treated for their atrial fibrillation. So my question was, well, how could this be? I saw these 2 patients back to back. How good is our prediction with the CHA2DS2-VASc score? And when one goes to the literature, it turns out that the CHA2DS2-VASc score is actually not very predictive. These are a variety of different risk scores that have been used in the past or have been tested in the past. And you can see down here the CHA2DS2-VASc score, although it's one of the better ones, has a C statistic of only about 0.6. That's only slightly better than a coin toss. And what that means is that there are many patients that we're probably treating who don't need to be treated, and there are patients that we're not treating to prevent stroke who probably should be treated. So the question becomes, how can we do better than the CHA2DS2-VASc? So first we have to understand what are the limitations of the CHA2DS2-VASc score. And the limitations essentially have to do with the fact that we're using epidemiologic risk factors, things that are predictive in large populations, to try to predict individual risk for a person. So, for example, if you have your 75th birthday, your risk changes because your CHA2DS2-VASc score goes up by 1. But nothing in particular happens to your physiology that actually changes your risk. Similarly, even something like hypertension is not directly linked to the pathophysiology of thrombus formation in the heart. So how do we overcome this and get more direct physiologic information regarding thrombus formation? Well, this is just going back to medical school and thinking about what are the pathophysiologic determinants of thrombus formation. And this was described many years ago as Virchow's triad, including stasis, vessel wall injury, and hypercoagulability. While all of these factors may play a part in thrombus formation in atrial fibrillation, we all know that stasis is certainly one of the more important factors. In fact, there's a lot of data from transesophageal echocardiography that shows that stasis is an important predictor of thrombus formation and thromboembolic events. Using TEE, if you have a peak left atrial appendage flow velocity under 0.2 meters per second, that's a predictor of stroke. Now, of course, TE is not a very good tool to screen populations, so we thought we would think about a new way to evaluate stasis in the atrium. So working with my colleagues at Northwestern, in particular Dr. Markle, who joined us, we applied the technique of 4D flow MRI to be able to do this. Now, the advantages of 4D flow MRI, it provides 3D volumetric coverage of the heart, and it allows us to encode velocity in 3 directions. And as you see in these beautiful pictures here, we can actually look at flow throughout the heart. So this is rotating around, and the color coding here is by velocity. So in the next couple slides, I'll sort of unpack for you how we do this and how we can apply this to the left atrium. So for those of you interested in the technical aspects of 4D flow MRI, essentially, remember what the MRI magnet does is it aligns all your protons so that the spin is in the same direction, and then there's an RF pulse that knocks the protons off that direction. And what happens is you start to get precession, so you get a vector that spins around. And when you get a vector that spins around, you can measure both the magnitude of that vector and the phase of that vector. And what we're typically looking at when we look at an MR image is the magnitude image of that. If we encode the phase image properly, we can actually measure velocity. So for example, this one is encoded to measure velocity in the z direction. And you can see that when blood flows up, it's white, and when blood flows down, it's black, based on the encoding here. And then we can do this in all 3 directions, and then actually voxel by voxel get a determination of the velocity, and then we can do that throughout the cardiac cycle, and hence we have 4D MRI. It's 3D velocity over time. So this is just an example, still example to show you how effective this is to look at flow patterns. This is now looking at the aorta. This is a patient with a normal aortic valve. You can see here the nice laminar flow coming out of the aorta. This is a patient who has a bicuspid aortic valve, and you can see the disturbed flow patterns that occur here in the bicuspid aortic valve. Okay, so let's now turn to the atrium. Just show you an example. These are 2 patients. This patient, you can see, again, the color coding is here. So dark blue is the low velocity, light blue, green, and then red. So you can see over here, you have a lot of sort of green to light blue velocities and fairly normal flow coming in from the pulmonary veins. In contrast, if you look at this patient, there's a lot more dark blue and a lot more disorganized blood flow. So the data I'm going to show you is based on these patients that we've studied. There are 70 patients with atrial fibrillation. 40 of them were studied while they were in sinus rhythm. 30 of them were in atrial fibrillation at the time of scanning. There are 20 older volunteers and 10 younger controls. All of them had fairly preserved ejection fractions. And as I showed you before, we do 3D constructions, and then we segment the left atrium. So here is another example showing now this is a tomographic color-coded image here. So you see here a lot of green and red, so high velocity flows. This is a patient who has a CHA2DS2-VASc score of 1. And here in a patient who has a CHA2DS2-VASc score of 2, you can see, again, much lower flow velocities here, more in the light blue to green range. Okay, so how do we quantitate this? How do we analyze this so that we can actually compare patients? So this was a challenge, and we developed the following analysis tools to do this. For each voxel, we have a set of velocities over time, so we can generate this histogram, and then we can take all of the voxels and throw them into one histogram for the patient. So each patient has their own histogram of velocities over time, and we normalize that to 1, and then we can actually group all of the individual patients into a group histogram that allows us to compare across groups. The parameters that we look at then, we can look at the median velocity of this histogram, we can look at the mean velocity, and then we can also look at something we call stasis, which is the percent of LA velocities that are under 0.2 meters per second. And we can actually also develop what we call these stasis maps that actually show you where you have those velocities under 0.2 meters per second. So this is the one subject that I showed you that had the good flows, and then this is the subject who had the lower flows. So you can see the red here indicates more stasis. So now we can actually develop some visual tools and some analysis tools to be able to look at this. So here we have our young controls and older controls, our AF patients in sinus and our patients with persistent atrial fibrillation. And no matter which parameter you look at, you can see progressive increasing stasis or decline in velocity. So if we look at our stasis parameter, 37% in the young controls, 51% in the older controls, 67% in patients in sinus rhythm at the time of imaging, and then 78% in those who are in AFib at the time of imaging. And then similarly, if we look at the mean velocity, 0.26, 0.22, 0.19, 0.16, a continuous decline in velocity, and all of these were statistically significant. However, in this box plot, we'll just focus here on the mean velocity image here, you can see that there's a fair amount of spread of the data. And what's interesting is if you look at the older controls, they span a whole range of velocities here. So do the patients in atrial fibrillation, in sinus rhythm at the time of imaging, and so do the patients in AFib at the time of imaging, even though they tend to actually decrease. So you can see that there's a fair amount of overlap. So how do some of these parameters relate to some of our other typical predictors of stroke? So left atrial volume is obviously something very important, and we'll again just focus on the left figure here because they're all essentially show the same thing. This is looking at the mean LA velocity versus LA volume, and the dots here are just colored by the group that they come in. But you can see there's a negative relationship between LA velocity and volume. The R squared is only 0.3, so it's not very high. We look at age, there's actually a better correlation, but R squared is still only 0.46. If you look at ejection fraction, you have expected direct relationship, but notice that the R squared is 0.07, so it's not a very tight predictor. And then finally, when we look at this relative to the CHADS-VASc score, there's also a significant relationship, but the R squared is only 0.27. What I'd like to do, though, is look at this with you for a few moments and try to understand some of this. So first you'll see if we take a patient who's got a CHADS-VASc score of 2, you can see that some of them have very good flow velocities, what you might see in patients who have CHADS-VASc score of 0, whereas some of them down here have very low flow velocities and similar to what you might see over here. So I would ask you the rhetorical question, because I don't have the answer, of course. Might this CHADS-VASc score patient up here, let's say a 55-year-old with diabetes and hypertension who had a successful ablation procedure, might this patient not need anticoagulation anymore? Whereas the patient who's got low flow velocities, even though they're in sinus rhythm, maybe this patient does need lifelong anticoagulation. And this becomes an important question if you consider, for example, the 55-year-old that I just spoke to you about. If he derives really no benefit from the next 20 years of anticoagulation, and one assumes a 3% annual risk of major bleeding related to anticoagulation, when one calculates out what his 20-year risk of a major bleed is, it's 50%. So you're talking about exposing somebody up here to a 50% 20-year risk of major bleeding for no benefit. I think this becomes an important rationale why we need to understand this a little bit better. Not yet. This is a new technique. This is all conjecture. And one of the other interesting things that we're going to actually try to do now is to actually further segment the left atrium to be able to look at the left atrial appendage independent of the left atrium. So To sum up, I think atrial fibrillation is a heterogeneous group of disorders. We don't really have good pathophysiologic classification, good evaluation of the substrate. Most of the common therapies to maintain sinus rhythm have efficacy rates between 30 and 70%. Our anticoagulation risk scores have fairly moderate predictive values, and there are no real preventive approaches yet focusing on the developing pathophysiology. So I think better defining the left atrial substrate can have an impact on treatment outcomes. Left atrial stasis, we know, is an important contributor to thrombus formation. 4D flow MRI identifies significant differences in flow velocities and could be a potential predictor for thrombus formation in patients with atrial fibrillation. However, further studies are really needed to define the role of 4D flow MRI to improve stroke risk stratification and personalized decisions regarding anticoagulation. Thank you.
Thank you, Jeff. I think we had a fascinating session. We discussed the epidemiology, we discussed the approach to management, we discussed different methods of management, including ablation, and this fascinating data that will be maybe the future of risk assessment. So thanks for all the speakers.